Hi, good afternoon. Thank you for joining us for the Employment as a Social Determinant of Health presentation with Virginia Selleck. Let me go through some housekeeping with everybody today. Please remember that all participants will be muted during the presentation. There's a question and answer function on the desktop. Please feel free to ask your questions through that function. We had realized in the last presentation that the chat function had been disabled, and it had been disabled for a purpose, although it seemed like that was a beneficial thing for people to utilize. And so we'll make sure that the chat function is enabled for this presentation as well. I will be managing the chat and the questions and trying to get those over to Dr. Selleck for her to answer at the appropriate times. This session is accredited for 1 hour for social workers, general credit, LPCs, peer support specialists, psychologists, nursing, AMA, PRA. That's 1 hour of credit. For full participation is required to receive credit and will be monitored throughout this session. You'll receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. And additional information is available in the digital event booklet, excuse me. For those of you who may have participated in the earlier session, this might be a little bit redundant, but Dr. Selleck has no financial disclosures. None of the members of the Symposium's planning committee or any session moderators have any financial disclosures either. Dr. Selleck has worked with the rehabilitation field for over 40 years. She has experience in psychiatric rehabilitation and recovery systems reform, program development, implementation, funding issues, legislation, and policy. She has held leadership positions in state government, Minnesota and Missouri, and with community mental health providers both in rural Illinois, in Chicago, and St. Louis. She's also provided independent consultation to multiple other states, especially Nebraska. Currently, Virginia works under the contract for Econosis under the Department of Labor's Office of Disability Employment Programs and has been the subject matter expert for a number of states, most recently Iowa, Wisconsin, Indiana, and Colorado. And Dr. Virginia is a subject matter expert and is providing consultation to us in Louisiana for this Department of Justice agreement that we have today. So with that, I am going to go ahead and kick it off to Dr. Selleck for her to start.
Hello, everybody. And if you guys have been with us since this morning, you are getting a badge for having a lot of stick-to-itiveness. Thank you very much for joining us. And I know how difficult it is to spend all day on Zoom. I do it myself. So I'm glad to have you. And today we are, as Ann says, going to talk about employment as a social determinant of health. And I do have no financial disclosures. Ann already sort of told you who I am, so we can skip through there. The more I hear my introduction, the older I feel, but nevertheless, we'll carry on. I would love to know who you guys are. And as we know, this methodology is pretty tough. So all I would ask you to do is, if you aren't fitting in any of these boxes, that is to say, if you're not a transition coordinator, an assertive community treatment staff, a state policy staff, somebody from an LGE, mental health provider, VR, if you're somebody else that I have not mentioned, we'd just be curious to know who's all out there. So if you feel inclined, go ahead and just attach that to the chat box. The purpose for today is to talk about the connection between employment and health. Think of it as a consciousness raising experience for you. It is not always well thought of or immediately thought about how the connection between employment and health is really quite clear. We spend, many of us that are employed talk about our jobs giving us stress, and we often don't think about the incredible stress not being employed and the health-giving benefits of employment. So we're going to talk about that. I'm going to share some information about the early mortality of people with serious mental illness. We're going to talk about how work is a health intervention. I'll touch on the historical and current challenges and strategies that we have to overcome the challenges of getting people employed. And we'll spend a few moments thinking about how to assess and harness the resources that you already have in your systems that you might not be fully utilizing. So I don't know how many of you guys have ever played or seen a kaleidoscope. I don't know if they're still out there anymore, but it used to be a kind of a cool toy for kids, a long tube that you looked through up to the light, and you'd see this beautiful pattern. And then if you clicked it just one turn, the pattern would change entirely. And so what I want to suggest to you today is that if you haven't already made this click change in your mind, please consider changing your views about employment from that work is too stressful and that people can only hope for maintenance and stabilization, and that only a small portion of the people with serious mental illness that we work with can work. Click that kaleidoscope and go into thinking that work is both a recovery intervention and a path to better physical health. That is becoming more evident over time, and we'll talk a little bit more about that. Also, I will show you some data about the majority of people with serious mental illness want to work and can work. So my overarching premise, and I will go through some of the details on this, is that unemployment in the general population, by general population I mean the world at large, correlates with illness, substance abuse, domestic violence, lack of social connection, other adverse outcomes. If you think about people in your own life who have become unemployed, either through no fault of their own or just because something happens and they lose their job, think about what a detrimental effect that is on people's health. We are knowing right now with the current COVID difficulties of the large unemployment consequences that have happened for people and how disruptive that is, not just in terms of money, but also in terms of everyday life and how you relate to the world. Be aware that people with serious mental illnesses are unemployed at shockingly high rates, exceeding 85% in some states. I will show you a little more data about that, but hold that thought. If there was any other group unemployed at an 85% rate, people would be pretty concerned. Studies have also shown 10 to 20, depending on the study, 10 to 25 years of potential life lost for people with mental illness due to modifiable health conditions. And ultimately, employment is a health intervention, and that correlational studies have found reduced healthcare spending for people as their employment increases. So this issue right here, I got this slide from Gary Bond at the Westat Supported Employment Center, and the reason I'm showing it to you, even though it is from Finland, the study in particular from 2019 was done in Finland. They looked at 50,000 people from 1988 to 2015, and the reason it's more useful than some other studies is because in Finland they have much more adequate and accurate social data on what goes on over there, and they studied, it's a longitudinal study. Not only that, but they had a matched sample. So basically they looked at a whole bunch of people who had acquired serious mental illness, schizophrenia in particular, and compared their earnings from work as opposed to from benefits after their first hospitalization longitudinally. And without going into huge detail about the slide, essentially what it shows is that people rarely work after that first hospitalization. And there's a lot of reasons for that we're going to speak about and hopefully make some suggestions about how to getting past that here. So how are we doing on helping people with mental illness in the public mental health system to gain employment? I'm not sure how many of you are familiar with SAMHSA, the Uniform Reporting System. It's a reporting system that states have to send in data to the federal government, to the SAMHSA group, in order to get federal block grant money. And so one of the things that happens is that states have to report the numbers of people that are employed. So this national average in 2018, we're talking now about the numbers or the percentage of people in the adult mental health system who were reported as being employed at all during that year. And by employed, we're not talking about full-time employment or even half-time employment. We're talking about any work that was noted. Louisiana in that year was slightly under the average, and you reported 19.1%. So hold that thought now. Now we're switching over to this notion of mortality. I promise that I'm going to bring these things together in a minute. This slide shows you that there is an extreme amount of mortality associated with mental health disorders. That is to say, people with mental illness are losing many years of life because of modifiable health conditions, not because of suicide or violence, but due to modifiable health conditions such as heart disease, diabetes, COPD, things of that sort. So we got these two bits of information. We have people way unemployed. We have many people losing their years of life. And so I got to thinking some years back whether or not this might be a coincidence that we have shockingly high rates of unemployment for people with disabilities, and we also have high mortality rates. So what does this mean and what do we do? So fast forward to thinking in a new way about social determinants of health. It was thought some years back, the public health world used to think about determinants of health more in terms of things like clean air and water and avoiding toxins. But the current thinking, or it's not that current, in the last 10 years or so, we've heard a lot more about social determinants of health. And this list that you will see here is a pretty well-established list that many researchers note when talking about it, social researchers do. And so the primary ones I'm drawing your attention to are social status, stress, nutrition, employment, income, safe place to live, social support networks. If you see that slide, I'm sure that you are able to note the sort of the correlational effects between employment and many of the others. When people are employed, they tend to have more income. When they're employed, they can afford better food. When they're employed, they have higher social status, etc. When we look at, oh, I forgot I have this snazzy slide here. These are the preventable causes of death from SAMHSA, from the New England Journal of Medicine. And these are what are preventable. These healthcare, health behaviors. This whole pie chart would lead you to believe that essentially there's only 30% of the causes of death that are not within our control. We can't do too much about our genetics, right? We're born with what we've got. But the other things that affect people's mortality are their social environment, their health care, and their health behaviors. So 70% of these things are within our control, by our, more broadly, society's control and ourselves as individuals. I'm going to talk a little bit about an article that was written by Joe Maroney, although this particular study that he did some years ago with David Hoff, they did a very comprehensive look at studies going as far back as 1938. And this kind of turns another kaleidoscope. Their studies determined that unemployment tends to be the cause of, rather than the result of, increased mental distress, social disconnection, all of these bad things. So you want to reverse the thinking for a minute here. Think about this as a concept, that instead of people get sick and then they get unemployed, to people have long-term unemployment and it's making them sick. There is a paper that I'm hoping that you have along with your conference materials that was published in Psychiatric Services very recently. And interestingly, Joe Maroney and our friend Peggy Swarbrick, who I just presented with on person-centered planning, authored this article just a month or two ago. And it details more information about my proposition about how long-term unemployment is under-addressed within the community behavioral health programs. The highlights of that article, I know people are always busy and don't often have time to read as much journal stuff as you'd like, so I'm going to give you the cliff notes here, although it is not a long article, and I do urge you to read the whole thing. But for more than 80 years, there have been many epidemiological studies around the world showing a strong correlation between long-term unemployment and poor general health and mental health, even for people without pre-existing deleterious health conditions. And the shorthand way of that is what I said before. It's not that you get sick and don't work. It's more likely you don't work, which makes you sick. Therefore, clinical staff and mental health systems need to assertively help clients to really recognize the risks that are associated with long-term unemployment. We typically don't do that with people. Very often you don't see employment being raised up as important as other aspects that the mental health system seeks to address, like housing perhaps, or crisis services. When you think about the clear connection now between long-term unemployment and poor health, it's the sort of informed populace that we want people to understand that it matters to their health whether or not they work. The other takeaway here is that funders and mental health systems and individuals can support policies and practices, addressing long-term unemployment with the same urgency that we use to deal with any issue associated with such major disparities. So I really urge you to read that article, but we will talk a little bit more about it. This is just one little vignette from Kevin Martone of TAC. A man with schizophrenia told him he could cope with the voices in his head, but it was the poverty, the unemployment, and the homelessness, and the fact that he was going to die 25 years sooner than the general population. Those were the big issues for him. So back to these health factors from SAMHSA, let's think about the modifiable chunk. I think it was like our 40% back there, modifiable risk factors. These are in everyone's life. This isn't related particularly to individuals with psychiatric disability. It's for all of us. Modifiable risk factors are smoking, weight, inactivity, lack of access to care, social isolation, vulnerability, violence, medication and polypharmacy, and unemployment and poverty, and the separate silos of care. Now you can see that some of these factors are actually within the control of the people we're serving or us as individuals. Some of them are really systemic kinds of risk factors that those of us who are in the helping professions, the mental health system, as you're certainly doing in Louisiana, working on access to care, to make care more available, to help modify that risk factor, helping to have good coordination and collaboration across caregivers to avoid things like polypharmacy, and also to try to bring those separate silos of care together. But it is important to see that unemployment and poverty is a modifiable health risk factor that we can actually make an impact on. How might work affect these modifiable risk factors? Well, think about your own life. With respect just to smoking is the best example. I remember years ago, and I'm sure you guys all do too, that people could smoke freely in their jobs. They could, or everywhere in the world. When smoking became less possible at work, it automatically helped people to stop smoking so much. This is, again, a sidebar, but I'm sure you're aware that there's a much higher percentage of tobacco use with individuals in the public mental health system than the public at large. So anything that can assist people with reducing their tobacco use can be a help. Also, inactivity is reduced when you have to get up and move around to get to a job, at least back before COVID when we were all sitting in front of our screen. It also enhances socialization, reduces the isolation, and it creates people having more access to community and more chances to make friends and have a more enriched life. And then obviously, employment leads to income, which is certainly a way to get money. And those social determinants, again, are connected to being unemployed, which is a bad social determinant. And we know that, of course, the individuals that we're working with, many are on benefits of various type. And so as we approach employment, this is a small line here where it says careful benefits planning is critical, but it's a big subject that is a subject for another day, but it's a very important one. So then I would ask, this is a rhetorical question. If work is so good for people, then why isn't it seen along with housing as a central focus of the public mental health system? Well, having been in the public mental health system for 40 years, here is the answer. History and misinformation. We have silos of care and funding. Think about the definition of a silo. I enjoyed this, I looked it up. A system, a process, a department that operates in isolation from others, an airtight structure, an underground chamber. I don't know about you guys, but sometimes it does feel, if you are working in your own department or division, that you're in some sort of an underground chamber and you can't understand necessarily how the other outfit is doing their work. The barriers between us are definitely a difficulty when we're trying to assist people with employment. And then the other one is stigma and erroneous thinking about the importance of employment for the people we serve. So there's three key tangled issues regarding employment and the ability to provide it. One, for providers, that is to say. And you, as I've been talking so far, might be thinking about those barriers that you've encountered. You might be sitting there thinking about, what am I supposed to do about this? I'm not an employment person. I would offer that the issues that seem to be the most problematic with respect to helping people get jobs are falling into three different buckets. One bucket is how do you pay for the employment services? Another bucket is how to help people be willing to accept employment services. And a third is how to convince legacy treatment staff to support and deliver the services. Legacy treatment staff is a euphemism for people that have been around working for very many years. Many of us, I in particular, was taught when I first started in the field in rehabilitation that employment was too stressful and that we needed not to stress people, that they should wait until all their symptoms had remitted before we even thought about going to work. That has been turned on its head now from what we know about research and what we know about what produces results. And if you sat in on the person-centered planning session that we did a minute ago, you will know, and then you will know when you ask people what they want in their life, many people say they want to work. So again, working with people on what they want to do gets you to a place that causes people to be more engaged and active in treatment. So here are some of the historical and funding and policy concerns that have probably filtered down to those of you working sort of on the street level, or if you are working in state government, as I have done for about half of my career, worked in state government. So I understand the barriers. One important one is misunderstanding about the appropriate use of Medicaid under the rehabilitation option, and that funds the majority of states' mental health systems. The rehab option is one way of using Medicaid. People often think that you are forbidden for the word work to appear anywhere when you're talking about the rehab option, and this is erroneous. The use, and I'll talk more about that, but the essence of it is that whenever you're providing a rehabilitation service, helping someone remediate the effects of their symptoms of their mental illness in whatever context, that can fit under the rehabilitation option. Not the same thing as teaching somebody to run the fryer. No, that's not a rehab thing. You can't teach people, you can't buy them work boots, you can't do direct work training. But whenever you're working with someone around their symptoms, it's appropriate under the option. We can talk more about that later. Also, and this is a big one, I found this at highest levels in 2 states that I've worked in and many that I have visited. Policymakers often do not understand that the vocational rehabilitation agency resources are very small in comparison with the mental health system need. Picture the state, all the people in the adult mental health system in Louisiana, and call that a cantaloupe. Now, picture the money that is and resources that would be existing in the vocational rehabilitation agency, and VR takes care of people with multiple disabilities, not just people with mental health concerns. They're also working with people who are veterans or who have orthopedic issues or who have developmental disabilities. All of their funding is the size of an orange. So the need, which we just outlined a minute ago, when you think that you've got all those people that are unemployed that probably need assistance, there's no way, even if VR took every single person you tried to send to them and said, yes, we're going to be a perfect partner and we're going to work with everybody, they don't have the resources. So, and policymakers sometimes get busy getting mad at each other instead of understanding that the resources are distributed in that way. Also, confusion about the sequencing issues, about who pays for upfront versus long-term supports. And state directors of mental health all over the country have been challenged by those silos. People are now beginning to work to break them down, fortunately. So then we go back to how I'm preaching all this stuff about how people are unemployed and how bad it is to be unemployed. And I know that some of you are sitting out there thinking, well, the people I work with, do they even want to work? How do I know if they want to work? Here is one way that we know. These are studies that were done, as you can see, going back all the way to 1995, all the way up to 2015, by all different researchers in all different settings, asking people, do they want to work? And I'm not going to read every study to you, but I will tell you that an average of 65% in all those studies, with a high of 78%, especially, and I'd draw your attention to the young adults. That study in 2011, 78% of young adults experiencing early psychosis indicated a desire to work. And you'll remember that slide I showed you from Finland indicating that they might want to. Chances are it's not going to happen unless we do something about it. So there is great interest in employment. But people want to work. But remember, I mentioned benefits. People are afraid and they are confused about the effects of work on their very necessary benefits that people need to have a roof over their head and food. Staff are also very concerned, because staff who are not knowledgeable about Social Security work incentives and Medicaid policies are afraid and confused. They have spent a long time getting people on these benefits and are pretty skittish about doing anything that they perceive to be creating a barrier or anything that would cause people not to be able to continue their benefits. So what we have here, in addition to all those other barriers that I mentioned, we have the combination of fearful consumers and confused staff, which equals to no movement toward employment. Now, here's what I think. I believe that anybody that's working in social service, whether in direct care or policy, you're doing this because you care about people. No one's doing it because you're hoping to buy a Rolls Royce. We're doing it because we're interested in lifting people up and creating better lives. Also, we all did what we were taught to do, and with all evidence-based practice, change comes slowly and with difficulty. So the stuff that I'm talking to you about, just like we spoke before with respect to the person-centered planning, about how change can be difficult, some of the stuff I'm suggesting may be kind of a mind twister for you, and that's fair and that's fine. But we all did what we were taught to do. As with all evidence, we learned from the evidence. And we did not blame doctors back in history who didn't wash their hands because they didn't know they were supposed to. Now we all know that we're washing our hands 24/7 with this COVID. Think of that change. But also, change is critical to progress, of course. So, as again, many of us were taught that work is too stressful. Then nobody did, however, teach us about how stressful unemployment was. And many staff, as I said, labor long and hard to help people get SSI or SSDI, which requires, because of the way the system is put together, stipulating the inability to work competitively, but they are not taught about benefits planning. So it's kind of like, well, I finally got the person on, job over. I'm good, I don't have to worry about that. Well, but you do have to worry about it because people need work to get well. And again, there's our pictures of our silos. Agencies, individual at the agency level usually can't figure out how to pay for employment services. So take a breath here. And now that we know how important work is to overall health, what can you do in your own role? Think about your own personal role. Think about what message you are giving the people you serve about the importance of employment. So ask yourself that question. Ask yourself if exploration of employment is a goal on every plan you create. Not everyone, assuming that the person is involved and interested. Not everybody wants to work now, but it should be touched upon and supported at every review. I can't tell you the many service plans in my role as a state person in the past, doing certification visits and so forth, and seeing the person say, when they have to write down their goals, I want a job, and months and a couple years later, they're still saying that and no one has done anything about it. Remembering that that is a goal that needs to be, and also when somebody first comes into service or when someone is first leaving a nursing facility, work may be the last thing on their mind, but just because they don't want to do it now doesn't mean you shouldn't be reminding them about it down the line. Ask yourself if your agency measures employment outcomes. Is it something that your agency views as valuable enough to actually keep track of? And do you know how the agencies you link people with view employment? And I'm sorry, but my cat is here and she won't shut up. Move it. Does the agency brochure or website mention employment in any place that you're working with? Does the agency measure employment outcomes as an expected outcome of treatment, along with reducing unnecessary hospitalization and homelessness? So basically, is it raised up as a service, as a overall service outcome. This is all depending clearly on whether the person served is saying they want to work. But as an agency, the kinds of things that we know are moving people along into recovery should include employment along with the other things. Does the agency provide or link people served with benefits planning or financial literacy helpers? Those are other things. The other sidebar here that I notice a lot is I don't know exactly how your agencies, or if you are, using functional assessment tools. Some states have mandatory functional assessment tools that you look at, and there's different measures, you know, like whether people can do activities of daily living, how are they managing symptoms. Sometimes in the area of productivity, it is very seductive to give people so to say high marks on productivity just because they're able to go to the grocery store or do the laundry. In our culture, going to productive adults, if they are not homemakers taking care of children and so forth, are going to work or going to school. So we don't want to succumb to the tyranny of low expectations in that area. So things that can help you, I would ask you, remember we're talking about these policies, again, a rhetorical question, is whether or not you, in your role, need help to understand the policies, the rules, the practice guidelines about the appropriate use of your particular funding sources in support of employment. Do you need help with this? This is something for you to ask yourself when you go back to your work and think, well, if I want to help this guy get employed, how do I build that? Can I build that? Where does that fit? Is that psychosocial rehab? Where is that? How do I do that? Also, again, another sidebar, literacy is very, very key in employment. We find a lot of people who suffer from not being as literate as they need to be in these days and times. So finding a good way to keep track of that up front so you know that you have that to look at with the person. This is something for you at a later time. These are examples for how other states provide policy help for supporting employment in the context of community rehabilitation. These resources will demonstrate how rehabilitation and community support services are being used. So Missouri, there's a link there. Whenever you get a minute, just click on that link and you will see that's the rehabilitation option of Medicaid. There's a lot of detail there about how to stay on the right side of the Medicaid rules, because we all are not interested in getting audited. We all want to be providing appropriate services in the context of our billing systems. This will give you some ways to do that. The state of Washington's provider guidance also does that. And I've provided a handout, again, I hope you have that along with that article from Alameda County, California, which gives some really specific descriptions of how you might do these things and still be well within the appropriate use of the Medicaid funding stream. So we're going to try an experiment here and see if you can use the chat box, and we'll just try it for a minute. If you have any ways, if you have any ideas about how you could encourage more attention to employment outcomes wherever you are, in whatever setting you're in. I'll take a beat and let's see if anybody can figure out how to do that. And Anne may be able to see things that I can't see, or perhaps not.
I am looking at the chat box.
I don't even have access to the chat box the way the screen
okay.
is. So
I'll read the feedback that I'm seeing.
that would be great.
And so one of the more recent things that came through that an individual put is, who is the intentional or unintentional benefiting from status quo, psychiatric hospitals, agencies, insurance companies, pharmacies? In what way can behavioral health professionals challenge the system what appears to enable rather than improve a person's quality of life? Really useful information.
So unintended, the key thing, you were kind of garbled there, but it sounded like the key issue was what are the unintended consequences, or what happens if you keep people unemployed, who's benefiting from that? Yeah. Well, and I'll say a few words about that toward the very end. I don't know if people are benefiting from it. It has to do with how systems are made, some people say, well, if people go get jobs and leave my services, then I can't bill for these services. My observation has been in all these 40 years that there is a never-ending stream of people who need help. So it's not like there's not going to be people that are going to continue to need help. So it's a good philosophical question. I guess I think that everybody benefits when people do go to work, because the recovery outcomes that everyone is, it reduces fund. I mean, it saves money when people go back to work. It saves Medicaid money. So your money that you have that's small can be spread wider. So it's a more efficient way to assist people, is to get them there. Anything else in that box that I can't see?
Yeah, so there's a couple more other items that came through. Educate other professionals on options of keeping benefits and begin working as well on how not to lose benefits. Know the facts, how much individuals can earn each month without losing benefits. Another individual posted, set it as an agency metrics for success. For policymakers, set it as a requirement for planning discussion and included any QE reviews, quality improvement. I'm assuming that means reviews.
Yes. That person is my hero, whoever said that. All that I agree. I mean, those are all very, very important things, and it's really a systemic job. The issue about how much to work and not lose benefits is an important issue, but the bigger issue is, let's not keep people on benefits so that they can still have a life of poverty. When you think about how much people get on benefits, this is not your wine and cheese lifestyle, right? It is still poverty. And so our goal in life ultimately should be to have people get as economically and financially astute and well as they can. But it is very important not to have the rug pulled out unduly or too fast. I will say that this is an extraordinarily complex area. Everybody that works in mental health doesn't have to know all this stuff. All you have to know is somebody that does know it. There is a tool that is being used in a number of states. They've just now started doing it in Colorado. They use it in Minnesota. They use it in Michigan and a bunch of other ones, called DB 101, which is a calculator that helps people. This company puts together this calculator, and then people can independently plug in what their benefits are and what will happen if I earn $100 a week, $200 a week. There's various ways that people can figure those things out, but it requires attention, and it is complicated. I would imagine that your VR system there has benefits planners and possibly can link people, but absolutely, very, very key, very key. Shall we move on? Or do you have another?
There's some other recommendations, but we can certainly move on.
Okay, well, if I stop too soon, we'll go back to them, okay?
Okay, perfect.
So I want to point out that you can't do this on your own, and how you might think about getting help from your system at large. And this is, again, taking us steps way back. Many, as I pointed out, people with behavioral health concerns are not employed. And in Louisiana, as in other states, we have several systems to assist job seekers both with and without disabilities. I want to remind you guys of the workforce system. It is called different things in different states. American Job Centers, one-stops, that is out there. You have the Vocational Rehabilitation Agency. Behavioral health providers can help, in particular, anybody that is on an assertive community treatment team, of which there are quite a few in Louisiana, has an employment specialist that can assist, and rehabilitation providers. The key, of course, is to partner and collaborate. But here's a little map for you to think about how you might be helping people. This is a sort of a quadrant that has the X and Y axis. We're looking at people's need for employment help as high to low, and people's mental health needs from high to low. You will see that each box there has another idea about how those services can be used. So you might be a community rehabilitation agency, mental health rehab agency, that you might be down there in quadrant 2, where you're working with a person that has high mental health needs, but the person has a little bit of work experience and maybe could benefit from VR, you would collaborate over there. So that the 3 and the 2 is requiring that working across silos. The one down the box of number 1 has more to do with people who are having some good idea about their employment, maybe some work history, and maybe their mental health symptoms are under control. They can be managed by referring. So sometimes you're going to refer people to things. Sometimes you're going to really need to take them, to hand carry them. And then the full integration model, which is up there in the quadrant 4, IPS stands for individual placement and supported employment. That is an evidence-based practice that, to my knowledge, is not currently very broadly in use in Louisiana, but hopefully will be. That is a very intensive program that works with people who have both high mental health needs and high employment needs. This quadrant tool can be used at many levels. You can use it at your agency and think about how to assess people served according to your needs. Are they high or low? And then think about where you are in the state. If you are in New Orleans, you're probably going to have a lot more access to a variety of the VR people. There may be a community rehab program. There may be an American Job Center. You may have a lot of richness of things to do. If you're in some other part of the state where it is more rural, you may have to have different strategies. And the state can look at it as for opportunities to look for gaps and think about how best to collaborate. What nobody wants to do is to reinvent the wheel, rebuild something that already exists. If we have systems in our states and in our communities, we want to use the systems that we have, and we want to work collaboratively with them and then build the things that are missing. So again, this tool is flexible. Teams that are working, if you're working in teams or in agencies, need to think about, take inventory of your own local resources where people can get help around employment, and then figure out whether the person you're serving has the capacity to be working independently and following a referral, or if they need, if they really need your help to collaborate and perhaps accompany them to these various places. So that's a thing that can be thought about more in detail at your local spot. This is now, because we don't have a lot of IPS in Louisiana that I know of, I'm going to take a very quick detour into giving you a description of what it is. It is the most well-researched of all the evidence-based practices, and it is a practice that leads to a mainstream job in the community that pays at least minimum wage. The work setting includes people who are not disabled. The service agency provides ongoing support, and it is intended for people with the most severe disabilities. It focuses on competitive employment, systematic job development, rapid job search, integration of rehabilitation and mental health services. This one right there is key, and this is why on your ACT teams, that is a perfect example of how ACT integrates rehabilitation around employment and the individual's mental health services. But not everybody is on an ACT team, and so not everybody needs that level of service, but plenty of people need supported employment and need to have their mental health care integrated clearly with the people that assist them around getting employment. Zero exclusion, attention to worker preferences, and zero exclusion means if somebody says they want to work, you help them work. You don't say, no, first you have to go to this workshop, or first you have to be sober for 90 days. You just help them work. Attention to the worker preferences, personalized benefit counseling, and time unlimited individual support. This is the evidence. This is the E in the EBP, characteristics of randomized controlled trials, many studies, and most of the studies control group received the services as usual or sometimes best practices. This is the picture that really gives you the point. You can see all of the black lines, the tall lines, those are the employment rates in 28 studies compared to the control group. So you will see that all but one, I think there is a 28th one in China that where they had where the results were more like even. It wasn't particularly perfect, but for 27 of these studies, IPS is clearly for 27 of the 28 studies shows a significant advantage for IPS. This is the key here. this mean competitive employment rate. I know people get sick of looking at numbers and percentages, but you remember back at the beginning when I started haranguing you today, we said that there was like 80% of people in Louisiana who are unemployed in the public mental health system. For IPS, 55% obtain employment versus 25% for controls. So what we're saying here is that the reason it's a evidence, emphasis on the word evidence, based practice is that there's evidence that it works, that it enables people to get employed. It is also effective across many subgroups of people with serious mental illness, different diagnostic groups, including schizophrenia, all age groups, diverse ethno-racial backgrounds, both people with extensive or little or no work history, all levels of educational attainment, mild or severe psychiatric symptoms, extensive hospitalization history. These things are all, there's a lot, well, I'll get to that in a minute. There's a lot available on the Westat IPS Center website. If anybody wants to really dig into these studies, and I don't blame you if you don't want to take my word for all this stuff, it's always good to check the facts and check the research, and it is available. So I don't know how many of you guys know about Robert Drake. He is a renowned researcher and one of the developers of that practice that I just mentioned. One of the things that people get stuck on sometimes is working with individuals who have co-occurring issues with substance use disorder in addition to serious mental illness. And in 2012, and then I have another newsletter that he mentioned recently that I will say a few words about, but essentially about 50% of people, and I assume this is similar in Louisiana, may have co-occurring substance use disorder. The research is clear that pre-vocational services and work readiness programs do not predict success and indeed may hold people back. Also, that traditional abstinence approaches have changed. We've learned over time on the substance use disorder side that people become abstinent in fits and starts, and that harm reduction is a strategy that works in the area of people with substance use disorders, so that we should not be expecting people to be abstinent from their substance before we work with them in employment. As a matter of fact, employment can assist people into greater reduction of their substance use disorders. And many IPS studies have shown that people with active substance use could return to work and be successful. He just recently, excuse me, and I don't have a slide for it because literally just this week, Dr. Drake was in another newsletter, and he noted that long-term studies show that once people are employed, basically, he says, they stop hanging around hospitals and community mental health centers, they get on with their lives. His feeling is that as a researcher, and I quote, "It was amazing to see that employment is such a powerful intervention, more than medication, psychotherapy, and other treatments that they study." I'm sure that will cause a few people to raise their eyebrows, but that is his point, and it's an interesting one. So a key part of IPS, this takes us right back to person-centered planning, is listening carefully to what people say about work. Do they want to? And if they do, how do they? What kind of work are they interested in? Making as person-centered as you can. People have been so, I really call for you to really be sensitive and think about this. If you had been told since you were 20 that you cannot work, that it's too stressful, that the doctor has to say you can't work so that you can get Social Security, disability. And if you have been told this for, the last 10 years, getting people to begin to think about themselves in a working life requires a tremendous amount of patience and support to let people really open their minds to think that they're doing that. I also have to say that even though I am extolling the virtues of employment, and I will continue to do so, I'm not suggesting that employment is mandatory, that we tell people to go get a job whether they want to or not, just like we don't tell people to do anything else whether they want to or not. It is a person-centered choice. And choice of job, careful matching, the very key part of IPS that makes it work, is not that you just plug somebody into whatever job is available. And back in the old days, when we first started doing supported employment before IPS, you would go to an employer and say, I have 10 people that really want to work. Can you give me you know, 10 jobs, and I'll break them into half time, and we'll just plug people in. People will come and work at the McDonald's, or they'll go work at the zoo, or they'll do, and we plug them in. That is not supported employment. Supported employment is starting with what the person wants and working around their abilities and their wishes. So quickly, this is another link that I mentioned before in the quadrant. This is the longest link I've ever seen in my life, but it is a link for your Louisiana American Job Center locations. The American Job Centers are a wealth of resources. I have found in many states, in my former state of Missouri in particular, we did a whole road trip going around and talking to mental health workers all around the state, and they knew everything there was to know about if someone needed food, where the food shelf was, if someone was homeless, they would know where a shelter was, if somebody needed clothes. They knew all about those things, but they were typically very unaware of the American Job Centers. They might know about a community rehab agency, but this whole notion of the Louisiana jobs, or of the American Job Center locations, people didn't really know about. These are the kinds of tools that are found. This is from the federal website, but this is an expectation across the nation for the American Job Centers, which are open to all people. This is just anybody that loses a job or wants a job can use these. And as of a couple years ago, the WIOA Work Investment and Opportunity Act required these centers to become more accessible to people with disabilities, so that they should be able to, especially if you take somebody to one of these and find out what they have. There's a lot that can be done in those settings. And I'm looking at my time here, so I'm gonna not read to you, except really suggest that you take a look at this, and that you take a look at that link and see where in your area these centers are. Especially, this is so important now. Of course, with COVID, many people have lost their jobs. Unemployment is a very pressing concern for many. But the American Job Centers should have a handle on local needs, which employers are hiring, which employers are not. They should have quick information that will be useful to you if you set about trying to help a particular individual get a job. I'm going to close with this, and then we'll hopefully have a minute or two to chat. These are 10 things, almost 10 things, and I've been talking about this now since about 1980. This is a very old slide, and it has not changed. I'm not sure what to say about that. These are things that you can do to support work, even if you're not having anything to do with employment in your regular life. You're just a case manager, you're just a whatever you are. Do no harm. Don't discourage people from working. Encourage them. Have humility about your ability to predict the future, and the stories I could tell you about the people I told they couldn't do things and who made liar out of me. Balance your concerns about stress. Unemployment is also very stressful. Number two, this takes us back to the American Job Center slide. Learn about vocational resources in your locality. Network with people and programs to help people find jobs, and try to learn how other systems work and collaborate. It is so tempting to think that our agency or our system is the only one that really cares about people, and the rest of those people are just bureaucrats, okay? I know I'm overstating it, but sometimes you get really irritated. They don't answer my call, their procedure doesn't make any sense, whatever. Learn how other systems work and collaborate. You will be amazed at how many wonderful people out there really want to work with you on employment. Again, the benefits. Find somebody who knows this stuff. There will be somebody. And if you are losing this, I see Ann's faces there. That means I got to hurry up. Change your programs and services to accommodate worker schedules. Don't be having everything happen between 9 and 5 or 8 and 5. When people go back to work, they need stuff after those times. Look at your flexibility. Be sensitive to people's discouragement. All jobs are not equal. Person can be serious about wanting to work and still reject a job. Know what people have to complete before getting a job and what motivates them. Cultivate that rehabilitation mentality. Learn about ADA, and keep your eyes open for potential jobs and feed leads. So then you think about your own best idea. And Ann, I can tell, is wanting to say something. Ann, please speak. No, you weren't going to read me a chat question? No? Okay. I saw her face. It just caused me to do that. All right, so how much time do we have here? 3 minutes, right? 3 minutes, 3 minutes. So people out there, I can't see the chat box, but maybe if I get rid of this, if I stop sharing, then I will see Anne, and I see the chat box now. Let's see if there's anything in it. Oh, good. You told me who you all were. We have mental health provider, funder, social worker. Oh, a peer support specialist. All right. Yeah, the slides should be available. Yes, the answer to that is. And could somebody just say yes or no that you got the article that I sent and the example from Alameda County of how you can appropriately use the rehab option? Did people get that? Anybody out there in the world?
I have not seen that, Virginia, but I don't know if any of the participants can include it in the chat on their desktop, whether or not they've received it.
All right, well, that's all right. I sent all those materials to Mr. Amos, so I'm sure that he has some plan for how that stuff can be distributed, just as the slides from the person-centered planning stuff. Okay, no, people are saying they haven't seen it. Thank you, Michelle, and thank you, Shavella, for answering that question. So I really do want them, if we can possibly do it, after this symposium is over, if we have a way to connect with people to ship them out that article and that example. I hope that would help.
That.
Good.
We'll
Any other final
happens.
words for the good of the order? Comments? Concerns? Arguments? We don't have very much time to argue, but I always like a good argument. Anybody want to?
I don't think so. I will say, Virginia, that it looks like a lot of the feedbacks are individuals saying how inspiring, how wonderful and helpful they felt that this presentation.
Good.
There was one piece of feedback from somebody who's affiliated with vocation and rehabilitation, saying we only serve individuals who want to go to work. The problem sometimes is that families don't want them to go to work. We also refer all clients to a WIOA representative for an in-depth conversation about benefits.
Excellent, and they're entirely right that they should work with people that want to work. But it's the job of the mental health world to help people believe that they can work, so that there'll be an appropriate referral to VR if and when the time comes. So yes, I really appreciate that. The VR partner is just critical, but they're not all there is to it. The mental health system has to haul up their slacks and get moving to help people work too. You can't just depend on VR. And that's my story, and I'm sticking to it.
That sounds good. There was one question that came through, and we can address this. Well, it's 1:45, but it said, what happens when the job asks for a drug test?
Well, not every job does. And if jobs do ask for a drug test, that's a thing that the consumer or the person needs to understand. They have to choose. And there's many jobs that do not require drug testing. And of course, depending on what state you're in, states where, for example, marijuana is legal, recreational marijuana being legal, there's whole different systems about what they're doing there. So now employers are looking more about job function. So you're certainly not going to be a school bus driver and fail a drug test, but you might be a clerk at a convenience store and it won't matter. I mean, it depends on the job. But yes, that's always, it's real life. People have to cope with real life.
It certainly is. Well, with that, it's 1:45. We'll go ahead and sign off. Thank you so much, Virginia. I appreciate you and I appreciate everyone else for participating today. We will have our last session today. It starts at 2 o'clock. And the topic of that is resolution-focused crisis response with Kathy Maidenwald. I'm hoping that all of you will be able to join us for that session. Thank you all
so much.
Okay. Bye.
Go stretch, everybody.
I know. Virginia, I was going to ask you, did your cat do a financial disclosure form?
My cat. I was really afraid she was going to jump on the computer. I hoisted her out, but she's really unhappy today. She's used to me catering to her every need,
I understand. My dogs would be the same thing.
Okay.
I appreciate it. Take care.
Bye.
Bye.